Thank you, everyone, for joining us for our next candidate's presentation. I have the pleasure of introducing Dr. Sanmi Areola, who earned his PhD in environmental toxicology from Texas Southern University and currently serves as the Deputy Chief Administrative Officer for Health and Human Services for Prince George's County in Maryland. He has been asked to present for 10 to 15 minutes on the following topic: create a public health strategy that clearly shows stakeholders the connections between suicide, overdose, and community violence. Identify which of these public health areas you would prioritize if resources were limited, and explain how you would align departmental resources to support a sustained and focused effort in the area you selected as priority. So please join me in welcoming Dr. Areola.
Good morning. Good to see several of my former colleagues here. That could be a good thing or sometimes not, but hopefully it's a good thing. And thanks for having me, board members, board chair, vice chair, Sanmi Areola, and I was at this department for almost 18 years and participated in multiple activities and roles. And I opted for the notes rather than PowerPoint, so you can also take a look beyond today. And these are excerpts from things that I put together over the years. I have worked on virtually all the 3 topics you put on, and I'm currently addressing all 3 topics in Prince George's County. You'll also learn a lot about my approach to public health in this process. And so the 3 topics that we mentioned here: suicide, community violence, and overdose, are all huge public health issues of very, very significant concerns. I think more recently is when we are now realizing, at least getting the stakeholders to understand that we have to look at this from a public health perspective. A lot of these issues impact our very important population, the teens, youth, and our children, which makes addressing them even more important. And for me, I argue, as you'll see in my second paragraph, that these are symptoms and sentinels of our continuing inability to create conditions where our children and our residents can thrive. If we do public health the right way, our job in improving, promoting, and sustaining health is to create conditions where everyone, no matter how old they are, no matter what part of the county they live in, no matter what their ethnicity is or their sexual orientation or whatever, that everyone has the optimal opportunity to be as healthy as they possibly can. And we don't define health as just the absence of infirmities or diseases. We define health as a state of complete physical, mental, emotional, social well-being. When those things are not optimally present, we see a lot of these conditions. And so they will not just go away by themselves. We must pay attention. We must be very intentional in our efforts to develop an action plan and to put those action plan into practice. Second part of the question was for me to talk about the connections between suicide, overdose, and community violence. And that would, again, give me an opportunity to explain that health is very broad. Health is impacted by many, many factors. And more importantly, several of those factors are outside the purview of the local health department. So it makes it very important that when we address any of these factors, we have to look at them from the local public health system perspective. Many times, we can give as many shots as we want, and I know that you've increased your resources in behavioral health, and we can do direct care as much as we can. We're not going to do them at a scale that's wide enough or long enough for us to see the impact on population health. So we have to bring in and involve our stakeholders. We have to involve people that know the community. We have to involve people that will help us understand the community. Because a lot of the things that we do, the propensity for them to be successful depends on how clearly the assumptions we make represent the truth. So if the assumptions you make about the community is wrong, your assessment would be wrong, and the interventions that you choose to do will be wrong. And the only way for your assumptions to reflect the truth is to involve people that are impacted. You need to involve the community. You need to make sure that you understand the norms and the values. And so a lot of what we do, we have a lot of programs that we do. I think we need to do more in terms of moving upstream and impacting those social, economic factors, social determinants of health, including housing, including social services, including transportation. And congratulations to Nashville on the success of your transportation effort recently. Economics. If you are poor, your health is poor. It's simple as that. And all of education is very important, as you will see when we talk about these three things. All of them have a profound impact on the overdose, suicide, and violence. So we do not fully understand how these factors, this complex of factors, how they interact and how they result in some that are more susceptible than others. But we know very well that these underlying factors are common and related. Many of them are related to traumas. Many of them are related to ACEs, other systemic and historical inequity issues. We also know that these substances, because the brain has a finite number of ways that it works. So we know many of these conditions commandeer the neurochemical reward mechanisms in the brain, especially the dopaminergic neurocircuitry. The same mechanism that we used to learn, the same mechanism that we get a reward from, the so-called feel-good mesolimbic dopaminergic system. So when they do that, because of things like pain, and I just don't, take a look at opioids, for example. When we started the opioid issue, it was pain, people using prescription opioids to manage pain, and then they get addicted. And then we put a squeeze on prescription opioid. Guess what they did? They moved to heroin from around 2010. And then we put a squeeze on that, and now it's fentanyl and synthetic opioids that they're using. So it's not really the types that they're using, it's the underlying symptoms, underlying factors that we must address. And when I say pain, it's not just the physical pain, they're also emotional pain. That's why you see co-occurring incidents of mental health conditions and suicide, co-occurring incidents of severe mental health conditions and overdose, as well as violence. And so it's the same factors that promote the initiation and persistence of this that modify the reward mechanisms in the brain that keeps that seeking of that reward going. So you're constantly looking either to mask the pain or to get the high that you need. And so there are some of the risk factors to be clear. You know, this Surgeon General said a couple of years ago that one of the greatest public health issues now is lack of social connectedness or social isolation. And again, keep in mind when we define health, it's not just the absence of infirmities. It is a state of complete physical, emotional, mental, and social well-being. So risk factor is social isolation. Protective factor is social connectedness. Okay? Risk factor is low socioeconomic status, and quite frankly, if I don't want to be as tactful, I would say poverty. And protective factor is raising people up. A couple of years ago, we almost brought down childhood poverty through the legislation where we were giving kids monetary every month. And so poverty is a big variable, a big determinant of health. Educational achievement is a big risk factor. When I was here several years ago, there was, I don't know whether that was eventually published, but there was a study out of Vanderbilt that was looking at educational achievement and the number of times that a kid had to move during the school calendar year. The kids that had to move 2.5 times during that year performed more poor as you will expect in school. So a lot of the things that we talk about are very important to move up and as a community to create conditions where everyone can be healthy. That's why I always preach that what we need to do is borrow from Robert Wood Johnson Foundation and create a culture of health in every part of our county. What that means is that the healthier option is the default option. It's the easier option. We can, for example, tell people as much as we want to eat healthy. We can tell people as much as we want that we want them to be physically active. If I live in an environment, I can only pick from the options that are available to me. If I live in a place and there are no grocery stores for me to buy food, or I live in an environment I don't have money to purchase the food, you can do all the education and outreach efforts you want. If I can't afford it, I can't buy it. If you want me to be physically active, make sure that when I step out of my neighborhood, I'm not afraid of dogs running large. I'm not afraid of my safety. If you want people to be healthy, that's where you've got to intervene. Where you create conditions where everyone, no matter where they live, where they stand, can be as healthy as they possibly can be. And so under number 3, in terms of how do we address this issue, I try to break that into 2. First of all, again, it's got to be collectively done. The health department cannot do it by themselves. There are so many of these factors we talk about that are outside the purview of the health department. We have, and I know a lot of that is going on, I see Tracy and others here. We have to do this through the local public health system. Through whether it's collective impact or whatever. You have to bring the partners together. You have to cultivate those relationships. And you have to build new relationships, especially for those that are not at the table. And you have to do it ahead of time, not when you have a pandemic. So you develop a plan, a public health approach, that it's looking at those systemic drivers of health. By the way, so you know, a lot of the factors we talk about, we could very well be talking about diabetes prevention, type 2. Because when you have that, we have studies from CDC that shows that by doing these 3 things, telling people to eat more healthy, telling people to be more active and handle stress better, those 3 things delay the onset of diabetes by an average of 4 years. And a lot of people eventually don't develop that. And so if you stay at the level where you are creating conditions that support health, you are impacting multiple health outcomes rather than focusing and putting band-aids on treating symptoms like we normally do. And then you've got to implement that. Implement that means everybody buys into the plan. You buy into the strategy. And the strategies that you develop are based on your understanding of the norms and values, and the assumptions are accurate, and you carry people along, and you are doing your part as the health department. Your partners are doing their part, and you stay the course. You know, Dr. Sacha, former Surgeon General, said that a while back when he visited here, said leaders do 4 things. He said you must, as a leader, know enough. You must do enough, have the courage to do enough, and then you have to stay on it long enough, perseverance. You have to do those things for a long time before you get the results that you need. And of course, you have to remain flexible and be able to adapt your plans to local conditions, to funding requirements. We get a lot of our funding through grants, fed, local. And so funding is a separate conversation in local public health. I wish it were better, but that's what we have. So you have to be adaptable. You have to be adaptable to social preferences and tolerances and the political stuff. If we don't know that, we know that more about during the pandemic. Public health cannot just say, this is what the book says or science says, and we're going to impose this on you. It just doesn't work that way. You have to take into consideration the preferences of the community. So and then I went into just listing a lot of what public health approach means. It means that we are playing our role under Public Health 3.0 as public health strategists. We are not trying to do all the work by ourselves. We're bringing people together. We're getting data. We're letting data drive our decisions. We're having clearly defined goals. And if you scroll down further, I suggested a couple of goals for you. And you understand the root causes of these issues, what factors are contributing to them. You understand the complex interplay, interconnections, and shared attributes of the risk and protective factors. And then again, be sure that your assumptions truly reflect what you're dealing with. You make data-driven decisions. You track your process. You track your output. You track your outcomes. You refine your approaches as you go. You provide educational facilitation, outreach expertise. You conduct assessments of what's worked in other places. You keep in touch with what science and research is saying. And then again, the goal is to minimize the risk factor and enhance the protective factors. That's really when we say building community resilience. That's what it is. It is building those resilience, those protective factors, so we become a more resilient society, a more resilient individual. The two public health goals that I think it's important, note that I didn't get into the specifics of hire more violence interrupters or do that. I think there's a place for that. I stayed pretty high, which is where you are impacting those systemic factors and making changes in factors that impact even more than suicide or overdose, multiple health outcomes. Again, if we work, public health, we are bold enough to get to a place where our approach is to create conditions where everyone will prosper, we will be more successful. We won't see a change in 1 or 2 years, but we know in public health, we know what works for health. We know what works for health. We're just driven by funding and political pressure to address those immediate needs rather than just focus on building. Look, just imagine two neighborhoods. One is affluent, one is poor. I can tell you where health is poor. I can also go back and look at your budget, like I told the mayor yesterday, and tell you what you have invested in the last 10, 20, 30 years, and tell you where health is poor in your county. Because if you don't do the sidewalks, if you don't invest in them, if people are poor, that's poor health. And so if you want things to be better, you got to do things better. Change those contexts, change the environmental context. And it's not the individual level, we still have to do that. But more impactful is to change those contexts. That gives us not just immediate benefit, but more long-term benefits. And so that's what you see in my first public health goal, to create those conditions. And of course, we still have to deal with those immediate impacts and have steps, and that's what you see in the second goal. The part of the question asked me to prioritize based on limited resources. Again, I reemphasize what we want to do is to create a culture of health. That's the long-term plan. And if I have to prioritize, obviously I want to do that based after review of locally available data. But just from what I know and from what you have done, and I see that you still have the CMHSI in place, seems like community violence is a very big thing. That's not really minimizing the impact of suicide and overdose. And so, but Nashville has been trying to confront the community violence for a long time. And then again, how do we align departmental resources to do that? And I'm just going to repeat what I've said just to make it clear, which is we saw that during the pandemic, and you see that every day. We have these emerging issues that almost take away all the resources in public health and takes us away from this systemic level intervention that will ultimately have bigger impact in moving the needle in health. What we have to do is make sure we don't lose track of those two, that we have things that we do immediately to acutely address these issues, but long-term to continue our efforts in creating conditions that are conducive for health. So again, we know things that work. Community interrupter, for example, I want to be clear, I'm not saying it's a bad thing, but you look at DC, they have invested a lot of money in community interrupters for years. Now they are questioning whether that's the right approach, whether it's working. And it's not because it's not working. You're not going to hire enough violence interrupter to change the trajectory in community violence. There's a place for it. But you got to look at the context and the environment and change. Again, affluence in the community is a protective factor. If people are poor, if people don't know where to go, if the environment is not conducive for healthy living, these things are going to persist. That's a level that we have to continue to do. So we have best practices. We don't have to reinvent the wheel. There are so many good programs there. Educational achievement is a big piece. We can continue to work with our schools as we've done to make sure students, it's easier for them to go to school. We can deal with the issue of transportation, for example, to make sure that this single mom who works at McDonald's hourly job can still go and seek prenatal care without having to spend 2 hours on the road, 4 hours back and forth. That's why they don't go for prenatal and postnatal care, because Transportation is a hindrance, and poverty is a hindrance. So that's the level that we have to stay to impact multiple aspects of health. And of course, re-entry programs, all of those things. I again have so many more information if that is desirable, whether I come here or not, that I'm happy to share. But if you're asking me for what my approach is, that is that I've done local public health for a long time. I have done virtually everything local public health. Public health strategist. I've taught it. I've reviewed for 2 of the top journals in public health for a long time. American Journal of Public Health, Journal of Public Health Management and Practice. I teach it, I think it, and I discuss with some of the best. We've got to go to those system level approach to make the change. And now I listed some of the potential members of the local public health system that could be very important in this work that we do. Again, I know you are doing work along those areas, but that's what I would do. Thank you.
Yeah, I think we're going to skip that. Yep. Okay. All right. So we are going to move.
Sorry.
Do you need a pen?
Yes. So, thank you.
Okay, so now we're going to move to the structured interview section. We have 10 questions for you and an hour for that. I'll have my same time things. We'll be keeping track of it for you, about 4 minutes per question. I'll keep you on track to be able to ask some questions at the end. We will go ahead and move right into questions.
Good afternoon, Dr. Areola. It's good to see you again. My name is Tanae Franklin, and I'm the chair of the Board of Health. Please take a few minutes to tell us about yourself. Summarize what interests you in the public health director position at Metro Nashville, and describe how your specific skills and experience have prepared you to assume this important role.
Thank you, Chair Franklin. Again, thank you for having me. To the entire board members, I'm Sanmi Areola. Currently, I'm the Deputy Chief Administrative Officer for Health, Human Services and Education in Prince George's County. It's a deputy mayor type role, so I oversee all of the schools, K through 12, University of Maryland, College Park, Bowie State University, the Community College. I oversee the library system. I oversee the Department of Health, Department of Social Services, and the Department of Family Services, which deals with the older population. Prior to that, I was Director of Health and Environment in Johnson County, Kansas. Johnson County, Kansas is the largest county in Kansas. It has about 25% of the entire population of Kansas. And I moved there from here just before the pandemic. I think my last day here was March 13th, and I got here. I was going to take a week off. As I was driving by, the county manager called me and said, "Can you start tomorrow?" So I jumped right in, no time to waste, because they found their first pandemic, and what a ride that was. And so I was there for 18 years, played multiple roles, deputy director, came in as a toxicologist, was director of Bureau of Environmental Health, and a couple of stints as interim director here. I just did multiple things. And what I've done really over my career and honed and put into practice the last few years is what I know, what I think public health should be. Your role as the health officer is twofold. You have to run a robust and efficient internal operation. And then you have to do health and move the needle in metrics of health. I think without having a robust internal operation, it is very tough to work with the community to change the health status for the better. And a lot of what I did here, I think my fingers are on so many things here, whether it's accreditation, performance management, or workplace culture, or protocols. So it's not just technical piece. It is administrative and running a good organization. And I, again, hone my leadership skill, pretty clear about the kind of leader that I am, clear about the kind of leader that I want to be. I'm pretty clear about the kind of culture, organizational culture, that I want to build. And by the way, for me, that's really my approach to building an internal operation, is to ensure that you have the right culture, and the right culture is clear to everyone, and you over-communicate the culture that you want to build. And when I say culture, I'm talking about everyone understanding what we do, why we exist, how we want to treat each other, how we want to behave, and a commitment to the things that we want to do. And luckily, outside here, I've been able to implement that effectively. When I went to Johnson County, I really was brought in to implement principles of public health 3.0, which we did very well. We put the structures in place, and the stuff that I mentioned about creating the right organizational culture, we implemented that. And the acronym we use there is LEAP, which is Leadership Empowers All People. And the idea is everyone in the organization is a leader. We empower them to make decisions. We empower them to grow. We give them the opportunity to make mistakes. Our role is not to be scorekeepers or to be punishers. Our role is to create environments where they can be as successful as they possibly can be. So I've done that. I've done public health in every ramification. I've my very tried philosophy on how to advance health, and that's what I bring to the table.
Good afternoon, Dr. Areola. I'm Marie Griffin, co-chair of the board. What do you see as the most pressing public health challenges today? What do you foresee as the most pressing in the next 5 to 10 years? And what would be your approach to addressing them as the public health director for Metro Nashville?
Thank you. Excellent question, Dr. Griffin. I think that we are going to have another epidemic. Whether it grows into a pandemic, we don't know. But the pandemic was not the first one that we've had in a long time. When I was here, we had to deal with West Nile virus. We dealt with Zika. We had Ebola. So they are always going to come. By far, for me, though, the biggest threat to public health today in the next 5-10 years is workforce. The second one is funding, and I'll expatiate on them. We have struggled a lot with the public health workforce for a long time, especially when the boomers were retiring, and COVID did a number on the public health workforce. We, at one time, the number was around 600 public health directors that are either resigned, fired, or forced to resign. Now, I don't know what you are seeing in Tennessee, but in Maryland, I am part of the Governor's Commission on Public Health, the workforce group, just assessing the state of the workforce across the state, and it's terrible. We are hiring health directors that I would not have hired 5-6 years ago because they don't have public health experience. We're hiring them because they are MDs, and all they have done really is diagnose and treat people. They don't have a construct of what we do in public health. But we bring them in because they're qualified, and we're training them on the job. And that's across the country. So that depth in public health leadership and experience, institutional memory, institutional knowledge, is going to be very impactful to public health. And but I think there are solutions to that, because you did ask before I go to funding. I think for me, and we were doing a lot of that in Nashville, and I don't know whether those continue or what the status are. But we bring people into public health from different fields. We have, like my friend John Finke, who's an engineer. We have accountants. We have nurses. We have different people. And we teach them job-specific competencies. And they get really good at what they do. Okay, what we need to do more, though, in addition to job-specific competencies, is to teach public health competencies. Second, also to teach leadership competency. Because that's the other piece. We promote people into positions. We don't equip them or train them on how to do the job. I think those three things, if we do them well, we might be able to mitigate or ameliorate some of the effects. But staffing, competent staffing, is going to be huge. It's already huge. It will continue to be unless there is an intentional effort to address that. Second piece is funding. And that's also not new. The funding in public health is not very good. Most public health are 60, 70, some are even close to 90% dependent on grants. And the way that grants work is it asks you to do very specific things. And that's what you do. You report back on those things. It shouldn't be the basis for a lot of what you do in public health. You should have core funding that fundamentally caters to your ability as a health department to do the foundational public health, to provide foundational public health services. And when I say foundational public health services, those are things that a public health department should be able to do or provide as services to their community. It is one of the key things that we look at in accreditation to see, as a department, you have those capabilities, competencies to provide those services to your community. So we have to do with funding. And again, here, before I left, and even where I am now, funding is an issue. We get a lot of our federal funding through the state. So when the state gets squeezed, guess what the states do? They hold on to more of the money. And so what trickles down to us is even small. And so you are trying to make budget meet and moving people around when the focus should be on what to do to continue to create conditions where your residents can be healthier. You've got increasing population. Nashville is one of the fastest growing cities in the country. You've got changing demographics. So funding is going to be an issue, and we've got to be intentional in making a case for a more dependable stream of funding for public health.
Thank you very much. I'm Dr. Lloyda Williamson, and my question, the first question is, how do you identify health disparities and inequitable access to public health services? And what strategies do you use to overcome those disparities and champion equitable access to public health services?
Thank you. That's at the heart of what we do in public health is what your question really is. It's getting a good picture of our community, getting a good picture of the health status, getting a good picture of where the gaps are, so that we can address those gaps. That's really when we talk about disparities and equity. And I understand the politics around the use of equity and those things. But in public health, we try to stay above politics for the most part and put ourselves in a way, because we have to provide services for everyone. You can't lose half of your population because you are leaning towards one side. But equity is central to what we do. Equity is basically saying this population, their health status is not where it needs to be. So then we need to make sure that's our job, to get that population up to where they need to be, whether it's by putting more resources, whether it's by education, and just use all of the tools that are available to us in public health. So very, very important. When I got to Johnson County, one of the first things that I noticed there was I didn't like the capability in epidemiology there. They just weren't enough for me, because what we do has to be based on data. And I made a case for that, and got 5 new epidemiologists there and a data analyst to join them. It wasn't easy, and I'm glad I did, because right when we hit COVID, if I didn't have those, I don't know how we would have survived. But that's one of the things that you do, make sure that you have the right resources. But at the heart of public health is addressing equity and disparities. That's why we look at populations that are impacted, whether it's TB or whatever, or environmental issues, so that we can target resources, not to push down those that are healthy, but to move up those that are not healthy. And so the strategy, again, like I said, is we don't want to sit down in the office and assume we know what's going on in the community. When I was here, as well as everywhere that I've been, you will see me in the community. You will see me have lunch, happy hour, talk to people. So you get the pulse at 10 community meetings. When we had the flood of 2010, I got to the office the following day. Our staff, environmental health staff, whether it's air pollution or whether it's a food program, we deployed all of our staff to the community. And a lot of what we did was just, we're passing out information on how for them to clean up in a safe way and those kind of things. But more importantly is to engage the community. I had people telling us that just having somebody to talk to was what they needed at that time. So our job is to build that relationship with the community. Be very intentional in nurturing those, enhance existing one, build new bridges where they don't exist, be intentional about bringing people that are not typically at the table, but equity has to be focused. So in some of my responses to the earlier question, I did talk about my 4 pillars of moving health in any community. One of them is a focus on equity. The other is building a culture of health, as I've talked about. The other is health in all policy and having a spectacular customer service. And so equity has to be central to everything that we do. And the way that I've done that is some of what I've talked about. It's working through the data, working through a local public health system, making the data speak. I'll give an example. If I still have some more time going on now, I'm very proud of in Prince George's County. Very first place that I've worked in where healthcare resources are just not adequate. And the model in Maryland is what's called the total cost of care. I know people in healthcare would know what that is. And the idea is to promote equity, but also to keep costs down. So Maryland has more savings from CMS than any other place in the county. But when you look at the data, which is what I did, I commissioned a study, Huron study, when I got there to map out the healthcare resource in our county and compare to the rest of the state. More importantly, to compare to Baltimore City and Baltimore County. And then I look at data that showed $400 million more yearly going to Baltimore City and Baltimore County, and more than Prince George's County and another county. And they made a case for whether it's intentional or not that your savings have been on the back of the people of Prince George's County. Last year, going to the governor, we brought in $38.8 million because of that effort to boost healthcare resources in the gap in the county. Last week, I was just informed that we're getting another $75 million from that saving coming to the county. So you use data, you make a case for the inequity, and you fight for those things.
Real quickly, what was the last pillar? I got equity, culture of health, health and all policies, and what was the last one?
Spectacular customer service.
Got it.
Yeah.
Thank you.
Thank you so much. Dr. Carol Ziegler. My question for you is, with limited funding and resources, how do you determine which program should take priority in advancing public health goals? And can you share an example of a creative approach you've used to stretch resources or reallocate funds to maintain critical services?
Right. So public health, it's been a handful of times when I had been involved in public health where I feel like we had enough resources. We hardly ever do, and that's always it's always limited. And believe it or not, Nashville actually funds public health much better than at least the other places that I've been to. And one of the things that we started working on here is there's some programs we have done for a long time that we continue to do. We, I don't know if staff remembered, I did pilot a program assessment program here where we are looking at specific programs and looking at historically why we do them and seeing whether there are people in the community who can do those things better than we do. And if what the current science is saying, whether our approaches have to be different. So we have to approach limited resources in different ways. And while we are advocating for additional resources, we also have internally to make sure that what we have, we're using them as best as we can. In terms of, I'll use the example of what we did here with food protection services when I was here, since I've already spoken about the healthcare in terms of utilizing funds. At one time, we were getting our permit funds from the state, and the state was retaining 5% of the funds. And then Steve was the director then, and then Hugh was the director of the state. Hugh was the director that just left out. We started that conversation with them, is how do we retain 100% of our funds? I don't know if you guys remember, 5-6 years ago, there was a huge increase in the number of applications for restaurants. And in fact, there was a time when by March, April, I had signed off on new restaurants, close to 100 new restaurants in the first 3-4 months of the year. So we were bringing in money from the permits. 5% was going to the state, so we stopped that first. And then we did an assessment here of making a case to our board here, but also to downtown, to let them know that those programs are paying for themselves. And so we put numbers. Here's how much we are bringing in. Here's how much the program is costing. You are not really supposed to be saving money from what we are doing. So release this money to us so we can improve the program. And that's what we did also. We brought in, I believe, 4 or 5 new positions doing that. But we also did quality improvement in those programs. We created environmentalists 1, 2, 3. Some of those people have not been promoted for 6 or 7 years when we did this. I did a rough estimate of what the optimal number of inspections an inspection should be doing before the quality is compromised, and we used that to calculate, and we redistributed and matched food and public facilities together. So each person was, so there's a lot of things you can do in quality improvement, but also while you are advocating for additional resources.
Public health initiatives often require diverse funding sources to be sustainable. What innovative strategies have you used to identify and secure alternative funding, such as grants, private partnerships, or philanthropic contributions? How do you build and sustain these funding relationships to benefit the department's programs?
Yeah, thank you. Seems funding is, as it should be, very, very important. I've given you an example, which is a big one in terms of from Maryland that's currently ongoing. And what is really good about using data to paint that picture and carrying all of our elected officials is it puts what they already know in a didactic, in clearer form, and they could make a case for that. The governor was there, and he said, "I like what you guys are doing in Maryland." It wasn't because of what we were doing was new. It was because we put that intentional effort. We had the study, we painted the picture, and then we used that to attract resources. Ultimately, for me, what I described in terms of the food program is what we have to do more. I was telling the mayor yesterday before I left, Kevin Crumble was the finance guy there. After I presented, very similar to what I'm talking about in terms of where I think we need to be intervening in health, then I challenged him then that you can make your budget reflect health. I say I can tell you where health is poor by looking at your past 10, 20, 30 years and tell you where you have invested money. And unfortunately, I left because he really took into that, just like Christine did with the health in our policy, and she was sharing with me how she's continuing those efforts. So ultimately, we have to be able to make a case to funders as to why health is important. In Maryland, the first year I was there, economic development was the county executive's priority, legislative priority that year. By the way, that's Angela Alsobrooks. She's the fourth black woman elected into the Senate, so senator-elect now. And so when I developed this, I approached her and said, can you make health your legislative priority? And I made a case for that, and she agreed. And that's why we were able to bring a lot of these things in. Of course, we had the data to back it up. There were legislative approaches. So I don't think we're going to get a lot more from the state and the feds, but we have to make a case for more resources from metro budget, no question about that. We have to take advantage of funding from our partners. When I was in Kansas, Health Forward Foundation You can Google that. It's one of those two big foundations there. Was one that I developed very strong partnership with. And they never gave us $1 million, but the little funds that we need to bridge gaps, they were constantly giving us. So building those relations with foundation, carrying them along with the plan that you have so they know what you are trying to do and they know how things fit in. I think those are work that you can do ahead of time to ensure that you build the fund. And I don't know if Nashville ever proceeded with that, like have friends of a not-for-profit entity like Friends of the Health Department. That's other ways that people are doing, and you kind of circumvent the bureaucracy of government and they raise funds from other entities. You can use that also to augment the funding. But funding stream has to be better in public health for us to do the work that I'm talking about. Yeah.
Okay. How would you handle a situation where two team members are in disagreement that's affecting the team's performance?
Would that be Dr. Harris and John Fick? Just let them fight it out. All right. So those things happen a lot. Again, because I was deputy director here, and I basically oversaw the operations. I saw enough of that. The way that I answer that question, though, is, again, seeing what I've gone through and done in the past almost 5 years, I think my approach is to focus on building the right organizational culture. And I was kind of, you build a cohesive leadership team, you have clarity, and those are the advantage from Patrick Lencioni. If you read that, you see some of that. So clarity, and that clarity include why we exist, how do we behave, including how we want to treat each other. What are the things that we're doing? How do we measure progress? Who's going to do what? I think that's very important. If you over-communicate clarity, like you say, or reinforce clarity about the kind of organization that you want to build, and you let people know. I know the bureaucracy kind of is hierarchical for us, but the kind of organization that I envision is one where everyone is a leader. We kind of work in parallel. It's not about, we're not punishers. We're not doing any of those things. We're trying to create environments where people can prosper and be better. Now, those things are going to always happen. You're going to get HR involved. You are going to get the facts of the cases. From my experience, I haven't dealt with several of those things. It often gets into personality issues, or in some cases, I am the supervisor. You should do what I tell you to do. And so for the most part, what I tell people is manage. If you're working with me, manage as if you don't have the authority to fire. Coach, talk to people, find ways to find common ground. And that's what I will continue to do.
Seemingly along lines of race and/or gender within your department?
Right. So that's an interesting question. We're not immune from what's going on in the rest of the society. There's no question about that. But I always just look at folks in military, for example, who, even though they have political leanings, they, as leaders, they are able to control their emotions, suppress their emotions. I think that's a key thing about leadership. Look, leadership is work. If you are going to work with me as a leader, a big jump from where I was 4 or 5 years ago, you have to be ready to do the work of leadership. I think the vibes that I give up, the vibes that people that are working for me gives up, I think that's very important as they permeate the entire department. We're here to do health. No matter what you look like, we want you to be healthy. No matter what your political leanings are, if you lean right and that's what you want to do, you've already lost half of the people to the left. If you lean left, you lose. So I try to stay as neutral as I can with those things. What I would do is just continue to preach what I think is the right thing to do, the right culture. It doesn't mean that those differences don't exist. It doesn't mean that we don't have a religious or political leanings. It just means that the least that we can do is how we behave, to treat everyone with respect. That's the kind of workplace we want to create. So I'm going to come back to the building the right organizational culture, and that's one of my favorite lines there. Yeah? So you better create those culture. You better shape the culture, because if you don't, whether you like it or not, culture is going to find a way to shape you. So preaching what kind of organization we want to be, what is acceptable and what's not, that's the long-term solution to that. There might be some issues that you have to deal with, but we're here to do public health. And I like diversity in the workplace. I like the fact that the workplace reflects the community that we serve. And I will say this, again, because of my 18 years, there's a lot of people sitting there that I've worked with over the years, black, white, a lot of people there that I've built relationship with. We don't always agree, but they also know that when I come forward, I am just saying it as I say it, and the only thing that I'm trying to do is the right thing. Always right? No, but they know. And building those relationships, trusting relationship, is a big piece of it for a leader, and that's what I bring to the table.
Thank you.
Thank you. How do you ensure important information is consistently understood across all levels in the organization, as well as by external partners and community members? And could you walk us through a strategy that you've used before?
Can you repeat that so I cover all those stuff? Okay?
How do you ensure important information is consistently understood across all levels in the organization, as well as by external partners and community members? And can you walk us through a strategy that you've used in the past?
Right. So communication and cascading information down the department, as well as across our partners, has always been a big challenge. And we have got to be intentional about doing that. And that's why when I talk about a clarity of purpose, clarity about priorities, it's not just for me or the leadership team, it is across the organization. And part of if somebody is going to do leadership work with me, and I'll say that again, leadership is work. And leadership is not just taking roll calls and checking what people are doing right or wrong. That's not what leadership is. Leadership is leading by example. Leadership is engaging your staff. Leadership is listening. I found out as the more that I get into leadership, the less technically sound I am, because I don't have enough time to read all of the science papers that I read. Now I read a lot more on leadership. So I depend on the skills of my staff to get things done. And so communication, you have to do that in multiple ways. I was talking to the communication person, and it's in there, is going to not forgive me because I'm missing your name now, yesterday. And I was saying one of the things I have really eventually seen outside here is a need to build a more robust communication team. That's one thing that here, for a long time, it was just Brian, and for a long time, it was just heavily tilted towards news and responding to and trying to put out fire. But that's not how to do it. You have to be proactive. There has to be clarity of what we're trying to do. Everyone, from the person who's picking up the phone, which, by the way, the impression that people have about the department will not be because of their interactions with me. It will be the interaction with their first point of contact. And it's the first person that you talk to, whether the inspector on the field or the person that picked up the phone. So everyone in the organization has to buy into what we are trying to do, has to understand what we are trying to do. And part of that is ensuring that we're cascading information. We're having a long time here we'll have different sessions with different programs. We have metrics where we are tracking the number of meetings and interactions that supervisors are having with their staff, just to make sure that people are cascading information and getting those information out. It's got to be very intentional, using multiple approaches, community meetings, Friday notes. I don't know if you guys still do those things, but it's got to be multiple approaches. But it's an absolute imperative, and you've got to have metrics to track whether what you're doing is working. Because you can ask people, have they heard about it? Have they not heard? And if it's not working, you should be ready to modify your strategies to ensure that they're getting the information.
What strategies do you use to engage community stakeholders in public health initiatives?
Right. So I would I think that was part of your question too. Some of what I've done, to be very precise, I know a lot of it has been going on in Nashville for a long time. Even when I was here, whether it's my deputy director or whatever, is engaging the community in multiple ways. I have always believed that health is very broad, and a lot of the things that we do that impacts health are outside of our purview. When I was here, I was constantly had very good relationship and communication with several departmental directors. I was meeting with the police chief, and Drake, that's there now, Chief Drake. We used to work out together then. Bill Swan, and the older police chief. Before I left, I'll meet with him. Scott Potter with water. You'll be in the community. All of the hospital CEOs, and I continue to do that. What I've done differently in Johnson County and in Maryland is very regular meetings of all the health systems, the hospitals, very regular meetings with all the FQHCs, and then quarterly joint meetings of all of them. Very regular meetings with the local public health system. Here, I think we call it the Healthy Nashville Leadership Council. All of those things is part of you got to be in the churches, you got to be in the faith community. And for those that don't know, I've been known to preach once in a while. So I've been to churches where I've spoken about health a lot. And so and you don't wait, that's the thing. When we had the pandemic, and that's across the country, we started offering vaccines to people, and then we were worried why people were not taking up the vaccine. We have to do the work prior to the pandemic. And the reason was they didn't trust us because we did not have a relationship with them ahead of time. So you go to a community that you've not interacted with and say, hey, I will even pay you $300 to come and get this shot. And so they're looking at you like, there's got to be something in it for you. You weren't talking to me, now you're paying me $300 to come and get a shot. So the work that we have to, the work of leadership, public health leadership, entails that we build those relationships ahead of time, nurture them intentionally. Be very intentional about bringing people that are not typically at the table there. And it's got to be an intentional effort. And we have to persist and do them. And every time that we hear somebody that's not at the table, it's an opportunity to improve health. And that's what we have to continue to do.
How do you approach situations where you feel strongly about an idea, but others have different perspectives? And can you give an example?
Okay. Can I say, for those, it depends on who? No, I'm just kidding. All right. Look, the beauty of leadership, and that's tough to do if you are new to leadership and you are technically sound. I go to meetings with the intention that nobody will out-prepare me. That just means I'll do all the study, all the reading that I need to do. But I also understand, just from my experience, that after I've done all of those and I get in the meetings and I talk about my idea, I see somebody come up with something that I have never thought about, that just almost makes a mockery of my perspective. So the beauty of things is to ensure that you get all the ideas. A couple of examples. When I was over the workplace culture protocol committee, we call it here, we pulled in people, about 20 of us from the different bureaus here. And we did have some people with very strong personalities on there. And my job then was to vet that group. And a lot of times I suppressed my thinking. As a matter of fact, that was, to me, was one of the better jobs that I did because I had absolutely no authority on people that were in the committee. I wasn't their supervisors. I can't tell them what to do. But after the initial growing pains, when we had rules and all of those things, it's amazing how individuals were going to do different studies, preparations on the different topics, and it would seem like everybody's on opposite end. But after 2 or 3 sessions, when everybody has the opportunity to say their piece, and then we come into when it's time to have consensus, it's amazing how they started working together. And once we once the group dynamics stabilized, I think we churned out almost like 17 or 18 different protocols. And those were really, really good. So for me, the ideas, the varied ideas that are based on individual trainings, individual experiences, you have to have all of those at the table and not feel, as a matter of fact, if as a leader, if you feel like it has to happen because you said it, I think you're in trouble, because that's all they are going to do. And when I got to Johnson County, what I wanted to do, again, I was brought in there to implement Public Health 3.0. And the final product that we put out before I left, we call it Moving Health Forward, JOCO, Moving Health Forward, JOCO. It's a blueprint for how to improve health for the next 5 to 10 years in Johnson County. And when I started the idea with my staff, I just started the idea, and I called it, I wanted to understand Johnson County. And so tell me, let's start putting the data together. Let's start with demographics. Let's start with high-level health metrics, related to quality of life, quantity of life, and those things. And the team just, I was very specific. I still have the original PowerPoint and documents that I gave them. I was very clear to them, these are just my thoughts. Run with it. And so it became kind of like a yes and type thing. People took it and just ran with it. I mean, there's so many data points, so many ideas, so many things, and they'll come to me, are we going too far? I said, no, just keep going. And by the time we did that, eventually we had to compress that down, obviously, but they have taken ownership of that because you allow them to have input in it. And to me, that's a leadership imperative, to not feel like you have to, your idea has to be the one that carries.
Thank you very much. As we wrap up, I want to ask, what questions do you have for us?
It's a privilege for me to be back in Nashville. I had, my basics in public health here. Always when I reflect, I have nothing but positives about my time here in Nashville. I built very strong relationships. I think all of the things that you need to do health is here. You have the resources, you have academia, you have the political connections, and even when I felt like it was time to go and be director of health, I was very selective about where I was going. If I wasn't going to have the resources that I need, I wasn't going to do it. And so looking at what you are trying to do, I'd always felt that Nashville deserves the best health director that it can get. One that has a good vision for public health, but also one that can run a good organization and create the right culture. So no questions for me. I think the first thing for me is good to see everyone here and looking forward to what happens next. But either way, I wish Nashville all the best. Thank you.
All right, so just to wrap up timeline, we've been keeping you, on top of that throughout the process. Our goal is to have a decision made before these people leave the building tonight. So you will be hearing from us either way, sooner rather than later. Again, if the decision has not been made, then, we appreciate your patience while you wait. But our goal is to make that very quickly.
Thank you. And good to see Carol, Teddy. Good to see you all. Thank you.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information on this and other programs, visit nashville.gov.